Imagine a health condition that, well, it affects millions, often really quietly, almost silently, before maybe announcing itself with a bang. Today, we're doing a deep dive into one of the biggest health challenges out there, diabetes mellitus.
Exactly. And we're going to try
Yeah,
and unravel it, look at the different types, how it gets diagnosed, and then get into the treatments, the strategies, the really comprehensive management side of things.
yeah, we've got this great chapter from a medical workbook, really detailed stuff on diabetes mellitus. Our mission, really, is to cut through all that, pull out the key insights for you, give you those moments where it clicks. We want to arm you with a solid understanding, whether it's, for yourself, maybe for work, or just because you're curious. Okay, let's unpack this. First things first, what exactly is diabetes mellitus at its heart?
Right. So diabetes mellitus, or just DM, it's basically a condition that messes with how your body uses blood sugar.
Glucose.
Glucose being the main fuel source. Exactly, the body's main energy. And insulin, which is a hormone from your pancreas, that's what helps the glucose get into your cells to be used. With diabetes, it's either the body doesn't make enough insulin or it just can't use the insulin it does make very well.
Okay. And it's really crucial, isn't it, to know there isn't just one kind of diabetes. There are two main types, and they're fundamentally different.
Absolutely fundamental. The real difference is how that insulin system gets messed up. So let's start with type 1 diabetes mellitus. The key thing here, it's an autoimmune process.
Autoimmune, meaning
Right.
the body attacks itself.
Precisely. The immune system mistakenly goes after and destroys the beta cells in the pancreas. Those are the specific cells that make insulin. So people with type 1 end up with, well, basically zero insulin, a total deficiency.
Wow. Okay, so no insulin production. How does that usually show up? Does it creep up on you?
Not usually, no. It often hits pretty hard and fast, like a short history, but with really significant symptoms. Things like unexplained weight loss, ketones showing up in the urine, that's ketonuria, and then what we call the classic polys. Polydipsia, that's being incredibly thirsty, polyphagia, excessive hunger,
Yeah.
and polyuria, urinating a lot. It's often diagnosed pretty suddenly. You see it a lot in acutely ill kids or younger adults.
Right, a very sudden kind of urgent onset then. So type 2 diabetes sounds like a whole different story.
Completely different ballgame.
Yeah.
Type 2 is mostly about insulin resistance at first. Your body's cells just don't respond properly to the insulin that is there, so glucose has a hard time getting in. Your pancreas, it tries to keep up, makes more and more insulin for a while, but eventually, it just can't sustain it. And that leads to an eventual insulin deficiency too, but it's a much slower process.
And the key difference in presentation.
The big thing with type 2, often there are very few symptoms, or sometimes none at all that you'd notice, which is exactly why it so often gets picked up during routine screenings, not because someone felt sick.
Okay, and this is where it gets really interesting for a lot of us, isn't it? Because type 2 can just sneak up. How often do you hear about people being completely surprised by a diagnosis? They felt fine. So for you listening, when should someone maybe think about getting tested, even if they feel okay?
Oh, it happens all the time. People are genuinely shocked. And yeah, that's why screening asymptomatic adults is so important. It's prevention, really. Generally, you'd think about testing for any adult who's overweight, based on their BMI, body mass index, especially if they have other risk factors layered on top.
Right. What sort of risk factors are we talking about there? What pushes someone into that higher risk category?
Well, there's quite a list. Things like not being physically active, that's a big one. Having a close relative parent, sibling with type 2 diabetes. Belonging to certain ethnic groups that have a higher risk, like African American, Latino, Native American, Asian American, Pacific Islander folks. For women, having had gestational diabetes, GDM, during pregnancy. Or even just delivering a baby over 9 pounds, that's a flag. Actually, women who've had GDM should get screened again maybe 6 to 12 weeks after the baby arrives.
Okay, that's good to know. What else?
High blood pressure is another one, or unhealthy cholesterol levels, specifically low HDL, the good kind, or high triglycerides. Certain conditions linked to insulin resistance, like PCOS, polycystic ovary syndrome, or seeing those dark patches of skin, acanthosis nigricans, and definitely a history of cardiovascular disease. Heart problems, vessel problems, that warrants testing.
So quite a few things to consider. What if someone doesn't really tick any of those boxes? Is it just a general age where screening starts anyway?
Yes. If none of those specific risks are there, screening typically kicks in around age 45. But if someone is overweight or has obesity, screening might start earlier, say 35, and even sooner if multiple risk factors are present. The general idea. If your first test is normal, you repeat it at least every 3 years. Maybe more often depending on where you started and your risk profile.
Okay, Makes sense. So someone gets screened. What are the doctors actually looking for? What are the numbers, the readings that signal diabetes or maybe prediabetes?
Right, the numbers. The key insight here isn't necessarily memorizing the exact figures, but understanding the types of tests and what it means when blood sugar is consistently high. For a diabetes mellitus diagnosis, getting any one of these results consistently usually confirms it. A fasting plasma glucose FPG, that's your sugar level after not eating for at least 8 hours, if that's significantly up. Or a random plasma glucose reading that's really high and you're having symptoms, like those polys we talked about, or losing weight without trying. Another one is the 2-hour plasma glucose after an oral glucose tolerance test, the OGTT. That's where you drink a sugary drink and they check your blood sugar 2 hours later if that's way up. And then there's the A1C test, which is, yeah, fascinating because it gives you that average picture over about 3 months if that A1C level is high.
Right, the A1C gives that longer-term view.
Yeah,
So what about prediabetes? Are the numbers just a bit lower than the full diabetes diagnosis?
exactly. Prediabetes, which doctors often call a category of increased risk, means your blood sugar is higher than normal, but it hasn't crossed the threshold for a full diabetes diagnosis yet. So for prediabetes, your FPG or your 2-hour OGTT result or your A1C would fall into a specific range that's, well, lower than the diabetes range, but higher than normal. The really important thing about prediabetes, it's a major warning sign. It gives you a chance, an opportunity to step in and potentially prevent or delay full-blown type 2 diabetes.
Okay, so once someone is diagnosed, what's the plan? What's the goal? What are we aiming for in terms of managing blood sugar? I'm guessing it's not just one target number for everyone, is it? People are so different.
You absolutely nailed it. It's definitely not one size fits all. While, a normal A1C is usually under 5.6%, and the ADA, the American Diabetes Association, generally suggests aiming for less than 7% for most adults with diabetes. The absolute key insight, the crucial thing, is that goals have to be individualized.
Okay, so why? Why is that flexibility so critical?
Well, it really boils down to balancing the good stuff, the benefits of tight blood sugar control, against the potential risks, especially the risk of hypoglycemia, which is dangerously low blood sugar.
Right. Low blood sugar can be serious.
Very serious, particularly in certain people. So take, for example, a young person, maybe 25, with type 1 diabetes. They haven't had it long. They're really on top of their management. Low risk of hypos. For them, a really tight A1C goal, maybe even 6.5% or lower, makes sense. It gives them the best shot at preventing long-term complications down the road.
But you wouldn't want that same strict goal for everyone.
Exactly. Think about, say, an 80-year-old. Maybe they're a bit frail, have other health issues like heart disease. Maybe they don't always feel the warning signs of low blood sugar. That's called hypoglycemia unawareness. For that person, pushing for a super low A1C could be dangerous. A fall, confusion. So a more relaxed goal, maybe 8%, maybe even a bit higher, might be much safer and more appropriate. The focus shifts, from hitting a perfect number to maintaining quality of life and avoiding those immediate dangerous lows. It's really about tailoring it to you, your body, your life.
That makes a lot of sense. So A1C is the long-term picture. What about the day-to-day readings, like before meals, after meals? What are the general targets there?
Good question. For the fasting blood sugar, so before a meal, the typical target range for someone with diabetes is usually between 80 and 130 milligrams per deciliter. And then for the peak post-meal reading, that's about 1 to 2 hours after you start eating, the goal is generally under 180. And that A1C test, how often is it checked? Usually it's at least twice a year if things are stable and on target. But if your treatment plan changes or if you're not quite meeting your goals, then it gets checked more often, typically about 4 times a year, so every 3 months.
Right, so we've covered diagnoses, we've covered the goals. Now let's get into the toolkit. What medications are available to help manage type 2 diabetes beyond those crucial lifestyle changes?
Absolutely. And the guiding principle always when choosing meds for type 2, it's thinking about the individual patient. You have to consider, well, everything, other health conditions they have, the cost of the drug, how it might affect their weight, and then, of course, how the drug actually works, its safety profile, and any other benefits it might offer, even beyond lowering blood sugar.
Okay, let's maybe start with the one that's often the first choice.
That would usually be metformin. Yeah. It's typically the first-line drug unless there's a specific reason someone can't take it. How it works, it's an insulin sensitizer. Basically, it makes your body respond better to the insulin it's already making. It's really effective, can lower A1C quite a bit. Plus, the risk of causing low blood sugar, hypoglycemia, is very low. And it's often weight neutral or can even lead to a little weight loss. And importantly, it's inexpensive.
Sounds like a good starting point.
Oh.
Any downsides?
The main thing people notice sometimes is some GI upset, like stomach issues, usually mild and often gets better. And you do need to be careful, or maybe stop it if someone's kidney function gets really low. They measure that with something called eGFR. Also need caution in frail or very elderly folks due to a very rare risk of lactic acidosis.
Okay. What about some of the other maybe older classes of drugs?
Sure. We have things like TZDs, thiazolidinediones. They also work as insulin sensitizers. Pretty effective, but they can cause weight gain, some fluid retention, and there's a risk of heart failure in people already at risk, so you have to be careful with them. Then there are the sulfonylureas, set to use. These are older drugs too. They work differently. They make your pancreas release more insulin directly. They're effective and cheap, but the catch is they can cause more hypoglycemia because they push insulin out constantly, whether your sugar is high or not, and they tend to cause weight gain.
Right. The unsmart insulin releasers, maybe, compared to some of the newer ones.
That's a good way to think about it. Yeah, some of the newer classes are definitely smarter in how they work. Take DPP-4 inhibitors. They also help release insulin, but they do it in response to glucose rising, like after you eat. So a much lower risk of hypos. They're weight neutral too. The downside, they tend to be more expensive.
And then there are those ones we hear so much about now, GLP-1s.
Ah, yes. This is where things get really exciting, I think. The GLP-1 agonists and the even newer GIP-GLP-1 agonists like semaglutide, tirzepatide.
Why are they such a big deal? What's so fascinating about them?
Well, what's truly groundbreaking isn't just that they're great at lowering A1C. They are very effective. And they also work as smart insulin releasers, low hypo risk. But the really big news is the stuff beyond glucose control. They cause significant weight loss for many people. And crucially, many GLP-1s have shown major benefits for people with existing cardiovascular disease, ASCVD, hardening of the arteries, and also for protecting the kidneys in people with chronic kidney disease, CKD.
Wow. So heart and kidney protection plus weight loss? That's huge.
It really is. It changes the conversation. The main side effects tend to be GI-related, like nausea or vomiting, especially when starting, but often improves. You avoid them if someone has gastroparesis or a history of pancreatitis.
Okay. Any other newer classes with those kinds of broader benefits?
Yes, definitely. The SGLT2 inhibitors, like canagliflozin, these work in a totally different way. They actually make your kidneys dump excess glucose out into your urine, so you're literally offloading sugar. They're also great for A1C, cause some weight loss, low hypo risk. The main thing to watch for is a higher risk of genital yeast infections or urinary tract infections because of the sugar in the urine, and need to watch hydration. And again, this really connects to that bigger picture, the holistic care idea, because SGLT2s have also shown really strong evidence for protecting the heart, especially in heart failure and the kidneys, similar to the GLP-1s.
It's amazing how these newer drugs offer so much more than just blood sugar lowering. But with all these options, where does insulin fit in? Is it always like the last resort for type 2, or are there times it's the right move earlier on?
Good question. Insulin is definitely not always the last resort. First off, for anyone with type 1 diabetes, insulin isn't optional, it's essential. They need it to live, period. Their body makes none. They typically use a combination basal insulin for background needs and bolus insulin for meals and corrections.
Right, but for type 2?
For type 2 diabetes, insulin might come into play right at the start at diagnosis if someone's blood sugar is extremely high, like a really high A1C, and they have those classic symptoms like intense thirst, maybe blurry vision. Sometimes, actually, a short course of insulin right at the beginning can help get things under control quickly. High blood sugar itself can make insulin resistance worse, so breaking that cycle can be helpful. And then, of course, insulin becomes necessary later on if other meds, even multiple oral drugs or other injectables like GLP-1s, aren't enough anymore to keep blood sugar in the target range, even at the best doses. That usually signals that the pancreas's ability to make insulin, those beta cells, are really starting to struggle and need external help.
And it's important to remember, not all insulin is created equal, right? There are different types that work differently.
Oh, absolutely crucial, yeah. The key insight is that different insulins have different action profiles, how quickly they start working, when they peak, and how long they last. This lets doctors try and mimic the body's natural pattern. So you've got rapid-acting insulins. They kick in super fast, like within minutes, peak around an hour, and are gone in maybe 4 hours. Great for covering meals or fixing a high reading quickly. This peak time is often when lows are most likely.
Okay.
Then short-acting insulin, like regular insulin.
Yeah.
A bit slower start, peaks in 2-3 hours, lasts a bit longer. often cheaper. For the background coverage, the steady need, we use long-acting insulins like glargine or detamir. They start working slowly, don't really have a distinct peak, and last roughly 24 hours. They provide that baseline. And there's also intermediate-acting insulin like NPH. It's in between, has a more noticeable peak, maybe 6-14 hours after injection, lasts maybe 16-24 hours, often given twice a day. Less common now, but still used, often due to cost. Understanding these differences is key to building the right insulin plan for someone.
Okay, so if insulin is needed for type 2, how do doctors approach starting it and adjusting the dose? Is it just guessing?
Definitely not guessing. No, there's a pretty methodical, stepwise approach. It's a careful process, always done working closely with the patient. Usually the first step is to target the fasting blood sugar, get that morning number into range. So you might start with a small dose of basal insulin, one of those long-acting ones usually taken at bedtime, maybe 10 units, or based on weight. Then the patient checks their fasting sugar each morning and the dose is increased slowly, maybe by 2 units every 3 days or so, until that fasting number is consistently in the target zone, say 70 to 130. If the sugar is really high, maybe over 180 fasting, you might increase a bit faster, like 4 units every few days.
Okay, targeting fasting first. What if that's controlled but the A1C is still too high?
Right. If the fasting numbers look good but the overall A1C isn't at goal, that usually means the blood sugar is going too high after meals. So the next step, step 2 really, is to start targeting pre-meal glucose levels, or maybe even post-meal levels eventually. This often involves adding bolus insulin, that's the rapid-acting kind, before meals. You might start with just one meal, maybe the largest meal of the day, with a small dose, like 4 units, or add it before other meals, depending on when the sugar is high. And again, you adjust those mealtime doses slowly, maybe increasing by a couple of units every few days based on the blood sugar readings before the next meal or sometimes 2 hours after the meal. Once doses get higher, adjustments might be made by percentage, like 10-20%. It's a very personalized titration process, always guided by the patient's individual glucose patterns and targets.
Okay, so it's crystal clear that managing diabetes effectively goes way beyond just tracking blood sugar numbers. What else needs to be part of the picture for living well with diabetes and staying healthy overall?
That is such a critical point. Yeah, comprehensive care is key. We sometimes use this little mnemonic, A, B, C, D, E, F, G, to help remember all the other important pieces, especially for type 2. So A is for aspirin. Low-dose aspirin might be considered for people at high risk of heart disease, but you always have to weigh that benefit against the risk of bleeding.
Okay.
B is blood pressure control. Super important. The goal is often under 380. And achieving that usually takes more than one medication. Things like thiazide diuretics, calcium channel blockers, ACE inhibitors, or ARBs are common. C is cholesterol, managing lipids. Usually involves a statin medication, sometimes medium or high potency, to lower that LDL or bad cholesterol. Maybe other meds like ezetimibe if needed. C also includes checking kidney function regularly, serum creatinine, GFR, urine albumin at least once a year, and considering kidney protective meds like SGLT2s, GLP-1s, or ACE/ARIs if needed.
Got it. A, B, C, D.
D covers diet, focusing on healthy eating patterns, limiting saturated and trans fats, maybe working with a dietitian for medical nutritional therapy, MNT, and dental care. Really important to keep up with regular dental checkups, as diabetes can impact oral health.
Makes sense. E?
E is for exercise, aiming for at least 150 minutes a week of moderate activity, brisk walking counts. Spread it out, no more than 2 days off in a row, plus resistance training 2-3 times a week, and eye exams. Regular dilated eye exams are crucial to catch diabetic eye disease early, usually every 1-2 years, but more often if retinopathy starts to develop.
Okay.
F is for foot examination. This is huge. A visual check at every visit and a thorough sensory exam at least once a year, checking for nerve damage using things like a monofilament, vibration sense, also checking circulation, and teaching people how to care for their feet properly.
And finally, G.
G just reminds us of the overall goals of therapy. It pulls it all together, the glycemic goals, blood pressure, lipids, activity, weight, everything else we've talked about. The real takeaway here: managing diabetes well is a team effort involving your whole body and a whole range of strategies, not just focusing on glucose.
Yeah, that holistic view is essential. Now, something that often comes up alongside diabetes is metabolic syndrome. What exactly is that, and why is it such a concern?
Right, metabolic syndrome. It's basically a cluster of risk factors that when they happen together, dramatically increase your risk for heart disease, stroke, and yes, type 2 diabetes itself. The critical insight is that it's the combination that's particularly dangerous. It's more than the sum of its parts, in a way. You're typically diagnosed if you have at least 3 out of 5 specific things: a large waistline measuring abdominal obesity, high triglycerides, those are fats in your blood, low HDL cholesterol, the good kind, high blood pressure, and elevated fasting blood sugar.
So it's this cluster effect. Why does having several of these together ramp up the risk so much?
Well, it's generally driven by being overweight or obese, being inactive, and having insulin resistance. Age and genetics play a role too. This combination puts immense strain on the body, on the blood vessels, the heart, the kidneys. It promotes inflammation. Over time, this leads to target organ damage. So yeah, it significantly boosts the chances of developing heart disease, kidney problems, stroke, and progressing to full diabetes if you don't already have it. Treatment really starts with lifestyle weight loss, healthy diet, more activity, quitting smoking. Then you treat each component aggressively to its goal statins for cholesterol, BP meds, diabetes meds if needed, maybe aspirin.
Okay, and shifting focus a bit, one of the really serious long-term complications we hear about is diabetic retinopathy, damage to the eyes. What should we understand about that?
Yeah. Diabetic retinopathy is a major concern. It happens when high blood sugar damages the tiny blood vessels in the retina, that light-sensitive layer at the back of the eye. There are basically 2 main stages. An earlier stage called non-proliferative, where you might see tiny bulges or leaks in the vessels, and then a more advanced stage, proliferative retinopathy, where new but very weak and abnormal blood vessels start to grow on the retina. These can bleed easily, and macular edema, which is swelling in the central part of the retina, can happen in either stage and really affect vision.
How would someone even know if they're developing it? Are there obvious signs?
That's the tricky part. Often, especially early on, there are no symptoms. Your vision might seem perfectly fine. It's usually picked up during that dilated eye exam we mentioned earlier. But if there is leakage, bleeding, or that macular swelling, then you might start noticing things, like blurry vision that's new, seeing floaters, little spots drifting around, or maybe holes or distortion in your vision. The absolute key insight here is that regular, comprehensive eye exams are non-negotiable, even if you think your vision is perfect. Early detection is everything.
And if it is detected, what can be done? What are the interventions?
Well, the number one intervention, honestly, is prevention. Getting and keeping those underlying conditions, the diabetes, blood pressure, cholesterol, under tight control, that's the best way to slow down or stop progression. If treatment is needed for the retinopathy itself, common options include laser treatment, called photocoagulation. This can help seal leaky vessels or shrink abnormal ones. There are also injections of medication into the eye that can help reduce swelling and abnormal vessel growth. And in more advanced cases, particularly if there's significant bleeding or scarring, a surgery called a vitrectomy might be needed to clear things out.
Wow, we have definitely unpacked a huge amount today. I mean, from figuring out the difference between type 1 and type 2 to understanding those diagnostic numbers, the A1C, and then exploring this really diverse and actually increasingly sophisticated toolkit of medications and lifestyle approaches.
We really have. And I think this deep dive hopefully underscores just how important early detection is and how diabetes care really has to be personalized, tailored to the individual, and that it's an ongoing, holistic thing. It involves so much more than just thinking about blood sugar levels. It's about overall health and well-being. Knowledge really is power here.
Absolutely. So thinking about all these advances, especially in medications with broader benefits, what do you think might be the next frontier? What's coming down the line that might move us beyond just managing symptoms towards, I don't know, true prevention or maybe even reversal for more people? Something to think about.